Well, I want to give a warm welcome to everyone who joined us tonight. Thank you for joining us for the webinar for sedation, oral versus intravenous administration. I also want to give a thank you for Stanley Malamed for inviting me to join him tonight. My name is Brady Moorhead. I'm a clinical director at Heartland Dental Care. I also work closely with our sponsor, Health First, which I'll get to next, but Stanley Malamed obviously needs no introduction. He's a dental anesthesiologist and emeritus professor of dentistry at USC, and he'll be joining us in a little bit. But I do want to thank Health First for their sponsorship and supporting us for this webinar tonight. You know, Health First has served the dental and medical customers for over 40 years, and today they rely on the support to about 50,000 facilities for medication, devices, and other readiness solutions. So we just want to thank them as the partner for our sponsorship tonight. And I'm going to turn it over to Dr. Malamed. There you go.
Thanks, Brady. So again, our discussion here tonight is to talk about sedation in general, but very specifically two techniques, oral sedation versus intravenous sedation. So let's talk initially, what is sedation? And if you go to the dictionary, this is what it says: a relaxed, calm, or sleepy condition that results from taking a drug called a sedative. And it's also number two, the act of giving a person a drug that causes calmness or relaxation. This is what we're doing. Why are we doing it? Well, this is one of my favorite slides. I have, over the years, looked at many surveys of common fears. And sadly for us, dentistry is usually in the top 10. This one I picked, public speaking, is the number one. This one, number two, is going to the dentist, fear of heights, fear of mice, fear of flying, and again, other fears. But dentistry, our profession, are we proud to be number two? I don't think so. So this is, I found this interesting. On the right-hand side, Jennifer D. St. George published a survey back, it was 2004, and it's a patient is seeking a new dentist. What are they looking for? This is what they want in their dentist. On the left-hand side is from 2016. There was a survey done in the United Kingdom, the top 10 reasons why people hate the dentist. On the left-hand side, things like the sound and the smell, the invasiveness, the drill, the anxiety. Number two is the pain. Number one is the needle. Look on the right-hand side of the slide. What do they want from a dentist? Number two, a dentist who doesn't hurt and a painless injection. The same two things people dislike, what people want. They don't want to be hurt, and they want painless injections. Okay, so what are our goals? The reason we're doing sedation is because people don't like going to the dentist for those very obvious reasons. So what are we looking for? What are the goals of sedation? And it boils down to this: the scared dental patient, everything we do for them, they're just overly aware of it. If you blow air in their mouth, I think everybody who's listening to us has had a patient, when you just blew air toward their mouth, they went, ow. When you touch them on their lip with your finger, they went, ow. They overreact. They overreact to everything, which makes our life as a doctor more difficult, makes our treatment of that patient more difficult. So the goals of sedation, the primary goal of sedation, is to distract that patient, to take that patient's mind off of what we are doing in their mouth while they're in a dental chair. Take their mind away from it. In addition, what we're doing is taking a patient who cannot handle stress as well. So we're talking about the extreme dental phobic. We're talking about the medically compromised patient, a person who is stress intolerant. And we're allowing them to receive, I would say, high quality dental care safely and efficiently. And yet another goal is to prevent medical emergencies. So let's take a look at that. This is a part of a survey an article I had published. It was way back in 1993, where I surveyed over 4,300 doctors in the US and Canada. And I was asking them questions about their experiences with medical emergencies. So long story short, 4,300 dentists reported that in their career, they had encountered over 30,000 medical emergencies. Okay, in red, the number one medical emergency by far, a little bit over 50% of all the emergencies in the survey was fainting, syncope. Now, very simple. Happy people don't faint. Scared people faint, which will lead us back into our program for today. Now, in addition to syncope, the emergencies here highlighted in the gray color: angina, seizures, asthma, hyperventilation, and the epinephrine reaction. These are called stress-related medical emergencies. A patient with angina comes into your office, they don't have chest pain. Okay, but if they get scared, if they get hurt, their heart rate goes up. And when their heart rate goes up, they have angina, anginal pain. A person with asthma, they're not having an asthmatic attack when they're sitting in the chair, but if you hurt them, if they get stressed, they're going to have bronchospasm. So these are emergencies. These 6 emergencies on this list, again, are called stress-related. Now, if we add up the numbers, these emergencies add up to 75% of all the emergencies that we see in dental practice. 3/4 of all the emergencies are related to stress and anxiety, which means something. We can prevent up to 3/4 of all the medical emergencies that do occur in the dental profession. So what are the techniques that we're using? And we go in here right now to the different levels of central nervous system depression. Now, these were first presented to the dental profession by the American Society of Anesthesiologists. This is the medical specialty group. And this is an article going back to 2002 because they were concerned about people, doctors, whether they're dental or medical doctors, who don't have their degree of training. Anesthesiologists go through rigorous residency programs. And a lot of anesthesia, a lot of sedation was now being done outside of the hospital by medical doctors and dental doctors. And sadly, in some situations, patients died. So these guidelines came out and they listed 4 different levels of central nervous system depression: minimal, moderate, deep, and general anesthesia. What we're dealing with here tonight, it's still afternoon in California, are 2 levels: minimal sedation and moderate sedation. So let's take a look at this. Minimal sedation would be the use of oral medications alone or nitrous oxide oxygen alone, minimal sedation. Moderate sedation is parenteral sedation, intramuscular, intravenous sedation. Moderate sedation on the left-hand side of the screen is when you combine oral sedation with nitrous oxide oxygen. Now, there's one proviso here. Whatever state you're in, you need to go back to your state dental board requirements. Most states say that oral sedation alone is minimal, nitrous oxide oxygen sedation alone is minimal, but once you combine the 2, you need a permit for moderate sedation. So again, I would recommend strongly, whichever state you're in, check that out. So let's take a look quickly at what do we call the spectrum of pain and anxiety control. And this is just one version of it. What we have here on this horizontal line are the different levels of sedation. The red vertical bar is very, very important. That is the point at which on the left-hand side, we have a conscious person. On the right-hand side, we have general anesthesia, requiring a totally different degree of training. But we start on the left-hand side. We'll discuss this briefly in a moment with iatrosedation. minimal sedation and moderate sedation. The word conscious sedation is no longer used. It is outdated, even though some state dental boards still maintain that term. But we have minimal sedation and moderate sedation. So the techniques of sedation that I want to discuss briefly with you right now are iatrosedation, which I may or may not be a new term for some of you, and pharmacosedation. Iatrosedation. It's very simply put, iatro means doctor, and sedation means relaxation. So what we are dealing with is you. It's the way you behave in front of a patient, the way you speak to a patient. The photograph on the right-hand side of the slide is of Dr. Nathan Friedman. I came to USC Dental School to start teaching in 1973. I started out there to start teaching drugs, sedation, nitrous oxide, intravenous sedation, and such. And they had a program at that time. The department was called Human Behavior. And it was how to talk to a patient, how to handle yourself as a doctor in front of a patient. So it deals with chairside demeanor. Okay, we don't give shots. We don't poke needles into patients. We don't stick people. Okay, those are terms that are very negative. They scare people. In Canada, when a dentist is going to be giving a local anesthetic to a patient, the doctor will say to the patient, I'm going to freeze you. Freeze you is a nice euphemism for shot. Okay, it's not a scary term. Other forms of iatrosedation include hypnosis, acupuncture, audio analgesia is a fancy word for music, video, and more in today's world, primarily in pediatrics, the use of virtual reality. But this is, again, non-drug techniques of sedation. When we talk about pharmacosedation, which includes the use of medications, we have these four routes of administration: oral, inhalation, intramuscular, and intravenous. So these are three surveys that were published by the ADA in 2008, the Academy of General Dentistry in 2007, and by Goodchild and Donaldson in 2011. And virtually all of the doctors responding to these surveys were general dentists. So let me just go to the next slide, because we're talking again tonight about two specific things. You see that inhalation sedation, nitrous oxide, far and away the most used sedation technique, well above 70% on all three of the surveys. Oral sedation, enteral sedation, between 40 and 70%. Parenteral sedation, which is again intramuscular, intranasal, intravenous, anywhere from 15% to about 30%. And again, the numbers you see here are primarily going to be general dentists. Now, this is a little bit dated. It goes back to 2008, but it's the most recent information I could find. This is from the American Dental Association, and it talks about the utilization of sedation, minimal and moderate, by specialty. So if we look at pediatric dentists, okay, they all use nitrous. All of them do. 65%, 2/3 of pediatric dentists are using oral minimal sedation, but the use of parenteral sedation is not used very often in the pediatric dental office. Endodontists, again, nitrous oxide, oral sedation, with some, about 20% using parenteral sedation. We go to periodontists, 75%, 2/3 of them, 77% are using nitrous, and not a lot of use of oral sedation by periodontists, but about half of all periodontists are using parenteral, in most cases, intravenous sedation. So with that, let me throw this back over to Brady and take it over, sir.
Thank you very much. So the next part that we're going to talk about is the part I'm very interested in, because I think it really parses the two between the oral and the IV administration, because it all gets down to how do we get the drug into our body and then start to work on the central nervous system. And the process by which the drugs get there will make a big difference in why you'd want to use one, either oral versus IV when you're working on a patient. So let's look at the oral route first. The good news is is convenient, right? I mean, our patients have taken pills in the past and they're asked to take a pill again. The bad news is it has to jump through two basic hurdles, mainly absorption and distribution. So when we look at the membrane, the tissue that it has to go through, so when we swallow something, it basically goes down an outside portion of our body because between our nose and our anus is just a big mucous membrane tube. And we have to liberate the medication from the pill in order to get into the epithelial tissue. And then it's absorbed that way. And once it's absorbed in the gut, then we can actually send it to the liver where it goes through what's called a first pass effect. Because after ingestion, drugs are absorbed through the GI tract and they pass to the liver before they enter this systemic circulation. So in the liver, they undergo some metabolic changes, and it results in how much bioavailability or how much medication we have to get that desired effect. Then it goes into, our bloodstream for distribution. So it's got to go first to the absorption process, and then it goes through a distribution process. Well, in the bloodstream, it can go all over the body, but our target organ is the brain. So we're trying to get it up to the brain. Once it gets to the brain, it's met with what's called the blood-brain barrier, which is basically the cell lining of the vascular system of your brain is very particular. It's kind of like a bouncer at a club. It lets certain things in and it keeps certain things out. And if it's water soluble, for instance, it just kind of bounces off the blood-brain barrier and doesn't allow anything in. So we have to make sure that our drugs are lipid soluble in order to get into the brain. Luckily, we are able to do that with some of our medications, but to go through the oral route, it has to jump through all these hurdles to get into the system. Where if we look at the IV route, if we think about the vascular system as getting on the bus, instead of having to go through the absorption process and then to the liver to get into the bloodstream, we go straight into the bloodstream. So we've skipped a lot of the hurdles in order to get the medication to the target organ or to the brain. So here we can look at the two differences again. And I think we can see that the IV route is much more efficient. It actually skips through a lot of the processes that would eliminate you having to be absorbed in a certain amount of time, because if you think about some of the things that would affect absorption in your gut, anxiety is certainly one of them, because it affects motility of the digestive tract and also how much food someone's eaten. There's many factors that may come to play on how effective your body may absorb that medication through the gut. So what are the advantages and disadvantages of each route? Well, we can look here that, the onset from oral is 30 to 60 minutes because it has to jump through those hurdles. Where if we jump right into the vascular system, the effects and onset of the drug is 20 to 30 seconds. So it's much faster. Also, because we can administer such minute amounts of medication in the IV at a time, we can do something that's what's called titration, where we actually can incrementally advance the medication until we get to the desired effect. Where if we do the oral route, we give one, bolus of medication, and we don't really know the outcome, and we can't quickly titrate it because it takes 30 to 60 minutes for it to reach desired effect. So we really have very little control. And this is the part that I find, kind of fascinating, is that if you want to use oral, you really haven't the ability to really schedule your patient, because if for some reason they come to your appointment and they are under sedated, then you have to ask yourself, do I administer more, and how long is it going to take to reach, and how much do I administer? Because let's say 5 milligrams of something didn't work, well, another 5 milligrams do the trick, or am I going to push them into an overdose position? And then if for some reason you gave them the small dose that you thought was small, and they come in and they're overdosed. Now you have a patient who you can't do treatment on legally, and you shouldn't do it because medically they could be compromised. And so you have to have someone and yourself sit by the patient and make sure that they can properly get to a state where they can be discharged. And then you could bring them back on another day with a different titration. But again, those are all day wreckers. All these situations where you're either under sedated or over sedated will really ruin your day.
So Brady, let me just check. Let me go back to that slide.
Yeah.
The state of California, you talked about on occasion giving a second dose of an oral medication, which most of us who teach sedation are adamantly against. Actually, the state of California prohibits you from administering more than one oral dose. And one of the reasons, very simply, is unfortunately, over these years, deaths have occurred when patients came into the office not quite sedated enough, and their dentist said, I'll give you some more, and some more was too much. And that didn't kill the patient. It was the lack of recognition and the lack of management. But again, the basic teaching today is one dose. As you said, one dose. And if it doesn't work, try something else or bring them back again. Okay, back to you. Sorry. Go ahead.
No, totally agreed. And I think every state has their own requirements as far as what we can do legally in our offices. So make sure you know your state's legal state and standing on what we are able to do as providers for sedation. And hopefully when you go through any of your sedation training, you'll be brought up to speed on that. And then just be current. You have to be current with what's going on within your state because the laws change. There's a lot of legal stuff going on right now in many states that may change how we are impacted by performing sedation on our patients. So be ready for that. When we look at our ability to complete a planned dental procedure safely with minimal inconvenience to both our patient and our doctor, what we mean by is, that's successful. If a patient is able to get through a procedure at a low stress, I'm talking about a relaxed position, that's where we want to be. As a matter of fact, when your patient is relaxed, you're relaxed. And when you're relaxed, you're going to be able to perform at a higher level. So I think sedation offers a really great service for many patients who are looking and seeking dental treatment that currently can't get it because they just are too afraid to go to the dentist. But also, don't discount what it can do for us as providers. It can really help us get through a procedure with lower stress, just as it is for the patient. So when we look at our sedation, is much more difficult than a general anesthetic. Obviously, general anesthesia is easier to get because they're going to an unconscious state. We do not want to go to an unconscious state. So I think it was mentioned before that the level of consciousness of a patient is kind of on a sliding scale from, you're conscious and aware of everything to a hyper level to oversedated, and oversedation can go to an unconscious state where you're not able to, clear your airway for yourself. You have no control over your airway. And so that would be a state that would be only for general anesthesia or deep sedation and for those type of providers that are providing that level. So we have to do a balancing act. We're kind of trying to make sure that our patients are not fearful, but we're not also going to a deep level that would be unsafe. And so we can look at I think the next slide talks about the therapeutic range of where we want to be. So minimal is at the bottom of that green, and deep is the red. We've got to be somewhere between minimal and moderate for most of our patients. And if we continue to give medication, we'll go up to that deep level. So you can see on the bottom where it says underdose, our patients are complaining, they're gagging, they're uncooperative, they have high anxiety, they have hypertension and pain. Those are where you're actually going to have patients also go into medical crisis situations, because if you are overly anxious and your heart rate is up and your hypertension and all the other things that are going on with your cardiovascular system that is being pushed because of the anxiety, it can push you into a heart attack or some arrhythmia. So we also want to make sure that we're watching that we know that sedation will actually help us by putting someone in a more tranquil position. Their cardiovascular system is much more controlled if they're just relaxed and they're less anxious. So we want to go there, but we don't want to go too deep, because if we go too deep, we can look at what goes on the top. And now we have a situation where the central nervous system is depressed. Well, now we're not breathing well. Our tongue may fall back and we can occlude the airspace. We can have respiratory depression that also comes with overdosing on medications that we're using that are CNS depressants, hypotension, apnea, and dysrhythmias. So all those things can happen if we overdose, and that's what we want to stay away. So we are having to play that delicate balance between the two, from underdosing and overdosing. And so our game of sedation is much more technical, and it requires a lot more attention and vigilance. So here we can look at the sedation success rates. As you can tell, IV sedation kind of, blows out of the water for the level of success, because we can titrate to a desired outcome. If they're not sedated enough, we can give a little bit more. And same as inhalation. If you do nitrous oxide, you can actually sedate someone at a very deep level by administering a higher concentration of the nitrous. But when it comes to oral, you're not able to make that adjustment on the fly, and that makes it much more challenging. And we know that any medication has a therapeutic dose range. So say 5 milligrams of something will work for 70% of the patients. Well, it's not going to work for everyone. And so you're not able to anticipate fully who's going to, be able to be under control with the medication and have the desired sedated effect, or are they going to be under or over sedated with oral? So it's much harder to get the success rate without many attempts. So when we look at the drugs that are used most commonly, we're going to use a benzodiazepine. They've been found, to be very effective and very safe, because the therapeutic range is in a safe margin for most of those medications we're using. The benefit for the IV is that we can also use an opioid, which would be good for analgesia, or it can bring down the level of pain and discomfort, but also it can synergize with the benzodiazepine and make it a little bit more effective. There's also the drug package insert comes with all of your medications. And I would probably say that most of you are not aware of what it says on the drug package insert for most of the drugs you're giving your patient. But I want to stress that it's very important that we understand, and actually it's a legal document, that we read and understand fully the medications we're using on all of our patients. It outlines some of the safety aspects of the medication, and also what not to do. So I think if you read it, you would have a little bit more grasp of what we're giving our patients, to make sure that we're playing and we're practicing in that safe margin.
Right. Before you go back to me, let me go back that slide. I cannot emphasize this enough. You're using local anesthetics. You're administering antibiotics. You're administering analgesics. You're administering sedative medications. Everybody knows why they're using this drug. Right in front of you, you see the package insert for a drug called midazolam. Now, that used to be the brand name Versed. So the indication for that drug, everybody out there knows what it is. It's to sedate a patient. That's easy. What you need this leaflet for, what you need this insert for, is when not to use that drug. And that's really the important thing. For every drug you're using, whether it's articaine, lidocaine, mepivacaine, any of the antibiotics, we know why to use it. But you need to look at this to find out which patients should not be receiving that medication. I just wanted to reemphasize that, Brady.
Thank you.
Okay, so let's talk a little bit right now about training. And I'm going to start at the bottom with intravenous sedation. Every state, and if we have any Canadians listening in to us, every province your dental regulatory agency requires you to obtain a permit from that province or state to administer IV sedation. You have to go through certain training. I am involved in two courses. I taught for 40 years at the University of Southern California, and I taught continuing education courses in intravenous sedation. I am now involved with the Oregon Academy of General Dentistry IV sedation course. And these courses run in excess of 100 hours. 100 hours, didactic, but the most important part of these courses is the clinical component. So again, intravenous sedation requires some rather vigorous training. Nitrous oxide sedation, essentially, and there may be one or two states that are different, but you graduate dental school in the United States or Canada, and you are allowed to administer inhalation sedation with nitrous oxide oxygen. It is, and I've given how many hundreds of lectures over the years on sedation. I believe that nitrous oxide oxygen should be the starter technique. You learned it in school, you should be doing it in private practice. Now, we go to oral sedation. Until about 10, I'm guessing maybe 10 years ago, no state had any, California did, but no state other than California required a permit for you to administer oral sedation. Well, that's changed. It's changed because more and more doctors are being trained to use oral sedation. Unfortunately, sometimes in continuing education programs that are not exactly the best. And problems happened. Patients died from oral sedation alone. They died or suffered permanent brain damage. So again, depending upon what state or province you're in, please, you have to check with your dental regulatory agency to determine if a permit is required. Now, the state of California, where I am, has always, easily going back 15, 20 years, a permit for adults, oral sedation for adults if you were 13 years of age and above. And now, and not now, but they've also had a permit for pediatric oral sedation, which is oral sedation for any patient who is under the age of 13. So again, please check with your provider, with your dental regulatory agency to find out what regulations will affect you. So let's then, since I'm leading into this, talk about some complications from from sedation. And the major complication when it comes to giving CNS depressant drugs, which is what we're dealing with here tonight, is oversedation. So that gets to this point right here. Patient comes into your dental office. They require sedation. You want to offer it to them. By looking at your patient, can you tell how much of whatever drug you want to give they need? And the answer is, of course not. So here's a great example. The Washington Bullets back at that time, they're now the Washington Wizards, I think. But they had a basketball player, Muggsy Bogues, who was 5'3". And they also had a basketball player, Manute Bol, who was 7'7". So think about that. Okay, we have 7'7", 5'3". Do these two individuals, can you guess which one needs more medication? And the answer is no. How about this? We have on the left-hand side of this of the diagram, we have thinner people. On the right-hand side of the side, we have obese people. Can you tell by looking at that person how much of whatever medication you want to give is going to be appropriate for them? And the answer is no, no. So what you see in front of you is called the bell-shaped curve, also known as the normal distribution curve. So let me give you an example of an older drug. The older drug is brand name Valium, generic name diazepam. Diazepam is an anti-anxiety drug. It's not used for sedation. It's not used to make you drowsy or sleepy. It is used as an anti-anxiety drug just to take away your anxiety. Okay, so comes in 3 dosage forms. Comes in 2, 5, and 10 milligrams. So what I'm going to say to you is the average dose of diazepam as an anti-anxiety drug is 5 milligrams. Take a look at the dark blue area, which says 3434. That would be the way a normal patient responds. If I gave 1,000 people 5 milligrams of oral diazepam, 1,000 people, 5 milligrams of oral diazepam, approximately 70%, 68% would respond appropriately. That's why this is called the average dose. On the left-hand side of that scale, there are about 15% of patients where 5 milligrams is not enough. These patients are hypo-responders. They need a larger dose. They need perhaps 10 milligrams. On the right-hand side of that scale, we have the other 15% where 5 milligrams is too much. They are hyper-responders. And what does that mean? It means instead of being relaxed, anxiety-free, they're sleepy. You've gone too far. So again, there's our problem. When you give a drug orally to a patient for the first time, you are making an educated guesstimate. If you go to a textbook, hopefully mine, go to the package insert for that drug, and it says the average dose is, I'll make up a number, the average dose for this drug is 1 milligram per kilo. Yes, that average dose is based on the dark blue area. The problem is there's a lot of variability in the way individual persons respond to drugs. And that's why with oral sedation, I'm going to use the term, it's a crapshoot. Okay, we're assuming, we are making an assumption the first time you give that drug that the patient will respond the way they're supposed to. 15%, as Brady mentioned earlier, it's not going to work. They're still anxious. What are you going to do? Are you going to give a second drug, a second dose of that drug, and wait another hour? In California, you can't do that. But the other 15% are oversedated. And oversedation means you stop what you're doing and you take care of the problem. Consciousness, unconsciousness. It's not black and white. It's a slow, it's a gradual slope downhill. An overdose of sedation is general anesthesia. Now, general anesthesia is not a medical emergency because we are purposefully giving a patient in the operating theater, in the dental office, we are purposefully giving a patient drugs to render them unconscious. So general anesthesia is defined as the controlled loss of consciousness. Now, if our goal is to sedate a patient and they wind up unconscious, by definition, that's an emergency. It's unwanted. Keep that in mind. So we go back now to the year 2016 and the American Dental Association. This was adopted by the House of Delegates in 2016, guidelines for the use of sedation and general anesthesia by dentists. And this concept, it had been introduced in 2002 by the American Society of Anesthesiologists, rescue. So let me just read this to you. Practitioners intending to produce a given level of sedation, moderate or minimal sedation, should be able to rescue a patient whose level of sedation becomes deeper than initially intended. So you are trained, if you're doing intravenous sedation, you're trained to do moderate sedation. You have to be able to recognize and treat a patient who goes into deeper sedation. If you're doing minimal sedation, patient is responsive to you. And if they go into moderate sedation, you have to be able to recognize it and to manage it. This is part of your obligation legally as that healthcare provider. And how do we handle these complications? It's not very difficult. This is the algorithm for handling any medical emergency. If anybody out there has heard me speak, and I've been doing this for 50 years now, Actually, July of 2023 will be 50 years. What do? You position the patient appropriately. You assess their circulation. You assess their airway. You assess their breathing. And those first 4 steps are called basic life support, CPR. D, definitive care. What can we do to fix the problem? If you've given drugs, if you've given an opioid to a patient, we have a drug called naloxone, a narcotic reversal agent. If you've given a benzodiazepine, triazolam, midazolam, diazepam, we have flumazenil, a reversal agent. So again, complications can arise. They can arise with local anesthetics. They can arise with antibiotics. They can arise with CNS depressant drugs. If we recognize the problem and we manage it efficiently, and you see what it right in front of you, that's all you have to do, full recovery will happen. So let me turn it back to Brady. Go for it, Guy. Brady.
Thank you. That was on mute. Sorry about that. Yeah.
Okay.
So how do we actually get to a safe place? And I think we talked about it earlier. It has to do with titration. Titration is the safe way to administer all the sedation medications that we want to use. And that's why the IV is the best route, because it skips all the hurdles right into the bloodstream, right to the brain. We can titrate, and in 30 seconds, we can get an effect. Whenever we look at the effect of oral, it's just too long. 60 minutes is a long time to wait. So you might achieve, the actual goal or end state that you're trying to get to because you were lucky. Maybe you've administered in the past to the patient. And so that would be my suggestion, is maybe if you do only do oral, maybe try a dose that Dr. Malamed was saying, which would be a standard dose, and then have them come in for maybe a cleaning where you're actually going to be monitoring the patient during the cleaning, and you can see the effectiveness of the medication. And then that way, when you're doing actual treatment, you can modify the level, because you can make a change to that medication on the next time you see the patient. When it comes to IV, you can do it right there on the fly. And as he said, if you mix inhalation with the IV, that actually helps as well, because you're actually able to titrate. But then it would become a moderate case and not a minimal case. Let me advance that. So oral sedation is just a good educated guess. IV, titrate to effect. That's exactly what we want. So oral sedation is what we consider the least controllable, least safe route, where IV is obviously the safest, and you're actually able to use the same IV line to administer life-saving measures if you need to, because the medication will be delivered right into the IV, as well as reversing agents. So to summarize, I think it's going to be pretty clear that all these techniques will provide some level of failure. And that's okay. We've got to anticipate failure. That's why we're going to be vigilant. We're going to be watching the patient. We're never going to leave them unmonitored. We're going to actually be watching the effects of the medication in the moment by looking at our monitors and being able to address the concerns, if there's airway concerns or whatever the medical situation that's going on. We're going to be able to address it because we've had training, and we know if we go too far, how to manage that case. Because legally, we have to be able to manage a case that's one level deeper than what we intend to be. So if you intend to be minimal, you have to be able to manage a patient in moderate. And if you're in a moderate, you have to be able to manage a patient in deep. So we have to be able to be ready, and our game has to be on. So that way, when the time comes and we do have to help a patient, we'll be ready to go. There are some patients, however, that you're not going to be able to take care of. And there may be regular patients that just cannot be sedated well with our normal medications, but especially when we're working with young children who have smaller airways anyway, and they have a harder time metabolizing the medications to effect, but also we have developmental, mental, and physical disabilities that will affect our ability to sedate. And there's people that are just extremely phobic. If you're already phobic and you're an anxious person and you're taking a lot of medications that alter your ability to manage life, you're probably going to be a poor patient in our office. So for those, we need to think and refer out for general anesthesia, because there are providers that can handle that level of sedation, but it won't be you. So make sure we're able to identify those patients and refer them to the proper provider. So on balance, our oral drug administration is going to be our least controllable route, where IV is going to be our safest and most titratable. We're going to be able to give the patient the level of sedation more adequately in the moment, and we'll be able to titrate to effect on most of our patients.
Brady, let me interject before you move on.
Yeah.
Intravenous sedation, we can titrate, okay? And it says on the slide, it's safer. This technique is as safe as you, the doctor who's giving the drug. When you take a course in intravenous sedation, you are trained to titrate. I'm repeating it, it's important, okay? You're trained to titrate, to administer the drug slowly. And again, 50 years of experience teaching this. If you continue to do this the way we taught you, you are not going to, and I can't say with absolute guarantee, you are not going to have a problem with over-sedating a patient intravenously if you continue to titrate the drug on every patient. You may not, the biggest problem we have, you as a doctor with IV sedation, is it seems kind of weird, is overcoming the fear that dentists have of starting an IV. Now think about that. How many thousands of intraoral injections do we administer every year? It has been conservatively estimated that if you practice dentistry full time, you're giving 1,500 inferior alveolar nerve blocks a year. Add to that all your maxillary injections. Yet you put a layer of skin in front of the dentist and they can't handle it. So it's overcoming that fear. Once that needle is in the vein, titrate, it's safe. Oral sedation, you're making a guess. And unfortunately, you can guess wrong. So back to you. I'm sorry, I just had to interject that.
No, I love that. And, it does bring me to thoughts, because we have, at Harlan, we have over 2,000 dentists and almost 3,000, or excuse me, over 2,000 offices and 3,000 dentists. So we have a lot of people that would like to do sedation. And sometimes they'll come and ask me, like, if it's okay to take an oral sedation class, because they don't want to do the dangerous one, the IV. That sounds like a real dangerous method to. And it's like, well, wait a minute. The IV is actually a much safer, but I think this slide right here kind of goes against what I think the common thought is as far as sedation in dentistry. There are some, advantages, I think, to oral, and mainly it's cost of training and application, like you said, because a lot of people are afraid to give an IV, but it's a very
easy. Oral sedation.
It's very, Once you get the handle on it, it's not a problem. And
well, let me just say, again, I can't help myself, but originally I'm from New York. That's why I can't help myself by interjecting. When we teach these IV sedation courses, I always ask these doctors, didn't one of your colleagues, when you told that colleague of yours you're going to take a course in IV sedation, they said to you, you're going to kill somebody with that? And that's the mental image. God, I mean, I'm knocking on wood here, but I've been teaching again since 1973. I've trained hundreds and hundreds of dentists in IV sedation. It is safe. It is as safe as you, the doctor who has his or her finger on the plunger of that drug. Okay, if you're safe, it's safe. Simple. Oral sedation, you give the drug, you're crossing your fingers, and you're hoping it works well.
I think sometimes it harks back to how much you're over promising to, right? Because you get in a trap where people think they need to be at a certain level of sedation. I'm talking about
Right.
a patient's perspective.
Mhm.
And then they feel like they didn't reach what you told them you were going to reach. So you
Right.
administer more. So I think sometimes it really comes down to how we present it to the patient,
Mhm.
and then practice safety in our offices.
Exactly. Okay, so let's go to the next slide right here. Okay, and this is
Okay.
let me just say this is really important also. You know, only general anesthesia has a guaranteed success rate of 100%. You have to learn when to stop. Sadly, again, over these years, whether it's oral sedation or any other kind of sedation, when problems have happened, very often it's because the doctor wanted it to work and they kept on giving more and more and more and more. And then, man, did it work. And they couldn't handle what happened. So please, you have to allow yourself to fail. You have to know when to stop. I mean, this is a great last slide right here. Whether it's oral sedation, whether it's inhalation sedation, whether it's intravenous sedation, you have to understand that there are going to be patients where it ain't going to work. Hey, same thing is true at local. Locals are fantastic drugs, but I have a feeling that every person out there who's listening has had that patient where you throw your hands up in the air and you say, I don't know what to do. I can't get that tooth anesthetized. We have to allow ourselves to fail. It's not the most rosy ending right here, but it is the safest ending right there. So,
Exactly.
Brady, these are our email addresses. If anybody would like to contact me or Dr. Moorhead, feel free to do it. Any questions you might have about sedation, or in my case, anything else, anything about life in general. No, that's not true. Medical emergencies, sedation, local anesthesia. I would be very glad to answer the questions. So are there any questions?
We do have a Q&A. I
Yes,
opened
we
the
do.
questions.
Yeah, I
And
see 'em.
for those of you that are listening, please, ask questions. This is the time for us to answer some at the end of the presentation. And I'll read some to you, Doc, if you can answer. Let's see, wasn't midazolam associated with stiff wall
No.
syndrome when given with fentanyl?
Fentanyl was all by itself. Fentanyl, when administered too rapidly, on rare occasion produces that stiff chest syndrome, but no, not midazolam. No.
Okay. And I got a few questions about where does one train for IV sedation?
Okay. Well, I'm going to be self-serving, if you don't mind.
I agree. You should.
Okay. I teach an intravenous sedation course it's in Oregon, Portland, Oregon. It's actually in a suburb of Portland, Oregon. And it's through the Oregon Academy of General Dentistry. If you want a place to go, listen to this. Okay? Go to learnivsedation.com. One long thing. Learnivsedation.com. And the information will be there. I'm saying it self-servingly. It is an excellent program. You will didactic, but you're going to be treating minimally 20 patients. You'll be doing the IV, you'll be giving local, you'll be doing the dentistry. And when you finish that program, you're going to be ready to go in your own private practice. So there you go. LearnIVSedation.com. It's in Portland, Oregon, and it's given twice a year. You can contact me personally if you want more information about that.
And also, you may want to check with your state, because there are some states, and I'm not sure, Dr. Malamed, if your course is approved in Florida, but Florida, for instance, is just a really tough state right now. They're not really approving any IV courses that aren't in residency.
You know what? Well, don't get me started about Florida.
Yeah.
For many, many reasons, and that's one of them right there. They've made it extremely difficult for a non-resident. No, I don't mean resident in Florida, but a specially resident oral surgery or GPR to get training in IV sedation. Yeah, but that's Florida. Enough said.
I hear some other states are talking in their state boards as well, so it's not going to be unique to Florida. But
yeah,
I would say that there is some grandfathering going on with IV training. So if your state currently allows it, you may want to go ahead and get IV sedation certified, only because then you can be grandfathered in if the state does decide to make changes. I'm not trying to make a big push for it, but I'm seeing some trends in state boards as we look across the country, that they're going to try to put up more roadblocks and hurdles. So
yeah. So there's one last question here I find interesting from Dr. Wartell. I would like to remind Dennis that using nitrous oxide oxygen at high altitudes requires a higher percentage of nitrous than the same effect at sea level. He learned this when I moved from Philadelphia sea level to Santa Fe, New Mexico. Absolutely. But again, the advantage of nitrous oxide is you titrate. So if you are in Santa Fe, if you are in Denver, Colorado, and you titrate your patient, if that patient had come to you from Philadelphia, and in Philadelphia, they will sedate with nitrous at 30% nitrous, they may require 45 or 50% for the same level of sedation at altitude. Excellent. Yes.
There's a question if we offer oral sedation or just nitrous or IV. And I can tell you, if you do learn IV, you'll probably won't ever use oral.
Right.
The only time you might use it is if there's an overly anxious patient and they aren't able to get a comfortable night of sleep. You might be able to give them an oral dose at nighttime, and then sometimes you might this is not something I do, but I hear other people that do it. They'll maybe give them a low dose before they come in, just so they can come in the door, and then you titrate your IV to effect.
Absolutely. Yeah, the night before and the morning of on patients who are really scared. Once that patient walks in your door, you got them.
Yeah.
Yeah, but too many patients are going to cancel at the last minute because they're too afraid. Absolutely.
Nitrous is very useful though. And I think it does. I mean, it's a very nice way to get someone a little comfortable at the very beginning, especially for the IV. So even if you're anxious for the IV, get the patient on nitrous, and that way you don't have a patient looking at you and you're, increasing your anxiety. So you might be able to get them started with a little nitrous. I do like nitrous and titrating it. But,
right. And the other thing about nitrous with IV is that number one, it's a vasodilator. So it makes the veins larger. And number two, it has a little bit of a numbing effect on skin. So whatever fear a patient has of a needle, I'm going to use the word poke, a needle poke, it makes it much more comfortable. And again, it also makes the veins larger, which for you, the doctor, makes the target easier. So there are advantages to using some nitrous oxide prior to the venipuncture.
Right. And I haven't heard of anyone using intramuscular
No.
in a regular dental setting, but is that something you ever recommend?
Well, here's the thing. You have a permit to do parenteral sedation, which is IM or IV. And obviously, IV has so many advantages over intramuscular. What about that patient who comes in, they're obese. They're still treatable, but they're obese and they don't have good veins. IM, if you really need to do something, an IM is acceptable. Intramuscular midazolam is a nice medication, but again, you lose the control over it. You can't titrate. But there are rare occasions when we do use IM when we can't start an IV on that patient.
Would you think IN or intranasal would be
well, intranasal midazolam has been used in pediatrics.
Okay.
And the problem with an adult is you're putting a liquid into a aerosolizer, if you will. And how much liquid are you going to put in before it starts to run down their throat? These drugs don't taste good. In pediatrics, where the doses are a lot smaller, it's not a problem. But with adults, intranasal it's not the best way to go. No.
And just for the audience, if you do use intranasal, that is considered parenteral. You have to have an IV permit to do that, even though you feel like you're giving it in the oral environment or nasal environment.
Absolutely. And also, for those of you who like to stick needles sublingual, I hear that. I hear strange stories very often. But if you start putting a needle into the below the tongue, that's parenteral, and you still need that sedation permit. You have parenteral sedation permit. So you got to be careful. Got to be really careful. Look, people do things that aren't, let me use the word kosher, that aren't, what we want to call standard of care. They do things until a problem happens. Once a problem happens, it becomes very, very difficult to defend these things. If you have a permit for, you're doing minimal sedation, there's no permit. But if you are actually doing moderate sedation and a problem happens, you're going to really have a very I'm telling you this from my perspective as a person who does a lot of medical legal consulting, and I do defense. There are times when it is very, very difficult for me to say to your defense attorney that we can defend the case. So please know what your state regulations are. And if you have a permit, or if your state doesn't need a permit for minimal sedation, do not do moderate sedation. Do not mix your nitrous with oral sedation if your state dental board doesn't allow that. I know it's a negative way to go, but please follow the rules. That's the important thing.
Yeah, good advice. Well, we're at 7:01. Should we take one more, or do we have
Let's
to cut
see
it
what we
off
got
now?
here. I've done, Dr. Selig, thank you. I've done surgery for 35 years. Great presentation. Total agreement with you. I like that. We have one here. As far as I know, fentanyl is a highly addictive drug. So in case of handling those narcotics in a dental office, well, you have to, this gets into the DEA, the forms you have to keep it in a locked, secure area. So, I mean, if you're going to have opioids in the office, I can't really give you the information right now, okay? But you need to be very careful with these drugs, absolutely.
Well, your state board is going to be more involved with how you take care of your patients, and the DEA will be more involved with how you handle your medications and what do you do. So, I mean, my recommendation is that you keep it under two locked in a locked box behind a locked door, if it's not in your on your person. And that way the chain of control over the drug is being maintained by only one person, and you should have the only key, and your staff team should know where that key is.
Right.
But you need to make sure you safeguard it heavily, because if it's found on the street and they trace it back to your office and you have no controls over the safety of the medication, you're going to lose your license.
True. And every milligram or every microgram of that drug has to be accounted for. So,
right.
Okay. I'm done. Brady, anything from you?
No, but I just want to say thank you. It's an honor, obviously, to talk with you and hear you. And I took your class over 10 years ago as well. And it was the best thing that I ever did in my career. So thank you so much. I really appreciate it.
Oh,
thank
my
you for
pleasure.
everyone attending.
Yeah, thank you, everybody. And again, our email addresses are right in front of you. Feel free to contact us. Thanks again. Bye-bye. Good night.
Thanks for attending this Viva Learning webinar. In order to get your CE credit, you will need to pass the CE exam. To do so, return to the website, make sure you are logged in, click on either CE in Progress or My Account. Click on the webinar title and take the CE exam. Thank you, and see you next time on Viva Learning.